monopole, and also a US of abdomen and pelvis. The results were normal. And as the mass measuring only 4 centimeters and with one small palpable axillary node, she was sent directly to surgery and for the mastectomy. Then she had a mastectomy in August 2017, and the path report showed invasive ductal carcinoma, grade 3/3 with metastatic lymph nodes, 5/13 positive lymph nodes for cancer. She's ER-negative. After that, she continued with adjuvant chemotherapy, ACT, and she received the last cycle of 175 Taxol in May 2018. And after that, she came in clinic for regular follow-up. And when she came in November, she completed dyspnea, and we decided to repeat the chest X-ray in December 2018. And the results show diffuse pulmonary metastasis, large white pleural effusion. And she is ER-negative, and my question is if she can. It seems she have to start with palliative chemotherapy, and my question is if she can start with palliative Taxol. Why? Even as the last cycle of Taxol was on May 2018.
So a young woman with ER-negative breast cancer with now metastatic disease to lung and pleura. In terms of her health, is she well?
Not well. She's ECOG 1. She lost weight, yes.
Okay. And is the effusion able to be drained? Would that be?
We drained the effusion and yes.
So hopefully feeling better.
Yeah.
I agree. Chemotherapy is her best option. She's, roughly 8 months from her last Taxol. I think I wouldn't exclude Taxol from her treatment regimen in the future. I think probably better to start with something that she hasn't been treated with before. Options would include single agent carboplatin or 5-FU. Triple negative disease may respond to carboplatin. And if she's pretty symptomatic, that may be an option. If I think you could be more, if you wanted to be more aggressive, if she was well, you could even try carbotaxol together. Although standard would be a single agent in this case.
I'm sorry, I missed it. Are we assuming she's triple negative, or do we actually have that data?
She was triple negative with her original cancer. We have the ER from the original, so.
No, I don't know if she is triple negative. No.
We have the path reports. If
we have, I think I said the path report for.
Yeah, the path.
Is there are they doing HER2 routinely now?
No.
It's negative according to the path report.
Triple
negative.
Okay.
But the doctor said, I had a question regarding what you just said.
No, battery HL2 for HL2 NEU negative 2. Negative, not true.
I have a little question. You said that if we like her original breast cancer was ER negative. So my question is that, do you think that it's a different cancer that she has, or is it the same, the recurrence cancer? Or if it is a recurrence, can the recurrence be like different from an histological point of view from the original cancer? Because you said the original cancer was ER negative.
So those are very good questions. It can change. I think this is probably a recurrence. It can change. My guess is in about 20 to 30% of cases, you can see a different marker when disease progresses. Going from ER negative to ER positive would be a much more unusual change.
Okay, so but more frequently, it can go from being positive to being negative.
Correct.
It's much more frequent.
Correct.
Okay.
For her?
Thank you. Yes. In general. Okay. Thank you. Doesn't come.
The next case is a 49 years old female patient who had a history of left breast mass since July 2017. She was seen in surgery in November. She had a biopsy confirmed invasive ductal carcinoma. After that, she was referred in oncology for follow-up. On physical exam, we noticed an unserrated left breast mass with left palpable axillary nodes. She had no history of ovarian cancer, no non-chronic disease. The basic labs was normal except in elevated white blood cells. She had a chest X-ray made on August showing a left breast mass, the tumor measuring 12 by 7.2 centimeters with inferior 3.3 by 2.7 centimeters. She had also 2 sub-centimeters pre-sternal nodules. When the case was discussed before, the plan was that she received neoadjuvant treatment. Then she started with neoadjuvant ACT and complete all the cycle in August 2018. But the response was not so good. But we decided to refer her in surgery to see if the mastectomy was possible. After discussion with the surgeon, she said she cannot have her surgery. Then we decided to place her on tamoxifen, but now, at this point, her disease is progressing. And
it's progressing on exam.
And yeah. And the here status is pending. And my question is, what we're supposed to do at this point?
And what makes you say the disease is progressing? Is it the exam or?
The left breast mass is occupying the whole breast, and she presents a new ulceration on the breast also.
Okay. And we don't know if she has systemic disease or metastases?
She had a chest X-ray, but she's supposed to do that today. We don't have another result. Maybe Monday, the result of the chest X-ray will be available. next Monday.
Okay. Okay. Any chance that she's not taking her tamoxifen?
She states that she take it regularly.
Okay. Okay. So I agree. She 49-year-old woman, you said, with locally advanced breast cancer at least, with progression on tamoxifen. She's also had neoadjuvant ACT up until roughly 6 months ago or 5 months ago. So I agree that chemotherapy is probably her best option at this point. It may help you in her overall management to have a sense of where the rest of her disease is at. So I think the chest CT would be helpful here. In terms of agents to choose from, I think carboplatin or 5-FU, probably, if I saw this patient in the office, I'd probably start her on something like capecitabine. So 5-FU may be a reasonable option here.
Okay.
So if I could just make one comment, and it has nothing to do with the care of the patient. It has more to do with the charting. You know, with the new forms, we're trying very much to catalog and classify all the patients who come through with various malignancies and make sure that they are staged correctly. And I'm looking at the staging that has been recorded on this form, and it is not really consistent with how the patient was described. So our records are only going to be as good as the information that's put in, and I don't know who is responsible for putting in the information, but clearly this patient has what seems to be a T4 lesion of the breast that looks, unless I'm misreading it, has been classified as a T1 lesion. Her nodal disease is probably even more advanced than the N2 that's been placed there. So it doesn't affect the patient's care at all, but it does affect record keeping and trying to keep a consistent and credible log of the patients who have come through. So if we could pay a little bit more attention to that, that would be great.
The other thing, I don't see her receptor status on, was she ER positive?
No, for now, we don't have the result of the year status.
Okay, so you were just treating her empirically with the tamoxifen.
Yeah.
May need to define empirically.
Yeah.
So 5-FU leucovorin was the recommendation, Liz?
Yes.
Yeah. Okay.
Any other questions or concerns on that case?
No, thank you. Okay. The last patient is 60 years old female patient who had a history of left breast mass since 2014, but she never had any follow-up until last year, 2018. She's HIV positive on treatment. She had also history of TB trait in 2010. She had a biopsy confirming invasive ductal carcinoma, grade 1/3. She's ER positive strong. She had a chest X-ray made on 2016 showing presumptive lateral left breast neoplastic mass, a bleeding subjacent anterior chest wall soft tissues without appreciable growth invasion through such and without obvious associated adjacent osseous erosion destruction. Multifocal bilateral pulmonary airspace opacities, possibly reflecting active pneumonia or other coexisting pulmonary disease. Several tiny pulmonary nodules. She had the US of abdomen. The result was normal. She had the basic labs made on the basic lab showing hyperleukocytosis 49, and we decided to order a myelogram. The results showed CLL. After that, she started on hormonotherapy, tamoxifen, with a good response. But since three weeks ago, she complained dyspnea. We asked for a chest X-ray on August, and we picked all the chest X-ray this month in January. I think it was Monday this week, and the chest X-ray showed diffuse opacities in the two fields, and now she complained severe dyspnea. My question is if she can switch to chemotherapy and what we're supposed to do with the results of the myelogram, because the results show probable CLL.
I'm sorry, I missed your last question.
Yeah. See? Sorry?
I missed your last
Okay.
question or statement.
Yeah, she had a myelogram score showing CLL. My question is if we're supposed to treat her also for that or waiting. Yeah.
Sure. So I agree that chest X-ray is concerning. Does she have any infectious symptoms at all?
Oh, she had the new basic labs made on Wednesday this week, showing the white blood cells continue to progressing. Now the count, come on, 18,000 blanc. 80,000 white blood cells.
Now 80,000. Okay.
Yeah.
And can you tell if they're predominantly lymphocytes or what the differential is?
Lymphocytes. The percent was, I think, 60.
60% lymphocytes?
Yeah.
Okay. Okay. So I agree. Cancer is one of the things I'd put on the differential and probably high up. But, you know, CLL does make people more prone to infections. So I want to be very sure that this wasn't an infection before I started chemotherapy. Going from 49 to 80,000 in a matter of weeks or months is pretty abnormal for regular old CLL. And even a differential of 60% lymphocytes with a white blood cell count of 80 would be a lot of other cells, presumably neutrophils. So I think I'd want to make sure that this was an infection before I started chemotherapy. Ideally, a chest CT might bring some more information. I'm assuming a biopsy of any kind is out of the question. The other option would be to try an empiric course of antibiotics and see where things stand. Do you think she's well enough to do any of that?
Yeah. Sure, yes. Yes, I think it's a good idea. She can have some days of antibiotics before to start chemotherapy.
Dr. Satir, is her HIV under control?
Yes.
Yeah.
Yeah.
She does have HIV?
Yes, right?
Yeah.
I thought it was checked both yes and no. So in summary, I recommend a chest CT, empiric antibiotics, and a reevaluation.
Okay. Okay.
Questions or concerns on that case? I know it's, or thoughts from other folks in the group, but that's a complicated case.
I think the chest x-ray is worrisome as well. I think it could be metastatic disease, but it's also worrisome for infection. So I think treating her with a course of antibiotics, empiric, and then reassessing makes sense.
Okay.
Are there any other questions on cases, Dr. Satir or Dr. Larmel?
No.
No?
No.
All right, we can switch gears and start the presentation whenever you guys are ready. I don't know if you want to rearrange the room at all to make sure everyone can see. We can give you a few minutes if you want to do that.
Yes, just give us 2 or 3 minutes for us to arrange.
Great.
Okay.
And then I will project the English version of the slides. And then if you want to project the French version, like we did last time, that seemed to work out well.
Yes, we will do that.
Great.
Okay.
Okay. Guys, we are ready. Do you hear us?
Yeah.
Yeah, so we have project on our side, the French version of the slides.
Great.
Yeah. And so we are here in the room, you're starting 9.
Great. We're just,
Sorry, okay.
there we go. We're pulling up ours right now.
What?
I can't offer you Kaylee's cranberry scones this morning, but instead I can offer you a short didactic lecture on update in breast cancer staging. So I first of all, thank you, Bob, for pointing that out on the, I think the second or the third case about why staging's important. That's a little bit about what we're going to be talking about this morning. And also we're going to talk a little bit about some of the new things going on in breast cancer staging. It used to be pretty easy. There was one way to stage, and every year it seems like there are new elements being added. So why don't we, you want to advance or you want me to advance?
Great. Just let me know.
Oh, okay.
Lorna, can you go around the room and tell us who's there?
Yes, so for now,
Thank you.
Yes, so we have Dr. Satya and I. We are here. We have an internal medicine resident who's on rotation, second year resident. We have Miss Pierre. We have Desamour and Magda.
Excellent.
Yes.
Hi.
So Haiti team, please slow me down if I'm going too fast, or if you have questions, please interrupt at any time. This is for you.
Okay.
In terms of the learning objectives of what we're going to go over, first of all, I wanted to review the importance of proper staging, why we do it. I wanted to do a brief review of TNM, which you're all familiar with. I wanted to differentiate a little bit between both clinical and pathologic staging, and also talk a little bit about anatomic staging, which is what they call the staging that you're doing right now down in Haiti without biomarkers. And also mention, just so you're aware, some of the updates on the 8th edition of the AJCC breast cancer staging that came out last year that do incorporate various biomarkers in addition to TNM staging and grade. Just to back up on the right, something you're all familiar with, just the clinical stage grouping, stage 0, non-invasive cancers, stage 1, small, less than 2 centimeter tumors without involvement of axillary lymph nodes, or in some cases, some very microscopic involvement of axillary lymph nodes. Stage 2, larger tumors, T2 tumors with minimal axillary involvement. Stage 3, locally advanced breast cancers, and stage 4, metastatic cancers.
Okay. So what we can do is, like, after each slide, if there can be a slide pause just for me to summarize what was just said before.
Perfect.
Yes, and we were joined by Ms. Tuvier and Ms. Beaujour to assist in the presentation. Donc, la présentation va se faire sur le stade du cancer du sein. Donc, il va parler de quel est l'apport, quelle est l'importance de la stratification. On va parler de la classification TNM, que nous savions déjà, on dit TNM déjà, et puis on va regarder tout. Parce que là-bas, nous faisons une classification avec histopathologie, et bien ensuite, on ne va pas qu'elle qui est up-to-date, qu'on va parler, nous, nous sommes vraiment capables d'appliquer encore, mais l'intéressant pour nous connaître, comme c'est nouveau bêteux. Good.
So why do we stage? Why is it important? Number one, it allows us to determine what the actual clinical staging evaluation should consist of. Certainly, a patient with early breast cancer is going to be staged differently than for a patient with locally advanced breast cancer. It also allows us to determine the clinical management pathway or utilization of our recently introduced protocols. And then finally, it allows both the physicians to understand what the prognosis is of the patient, and also to be able to convey that information to the patients and their families.
Donc, moi, c'est pas besoin de traduire ça, donc, mais qui est importance gain dans stade là. Yes. Go ahead. Yes.
So this next slide, I'm not going over in detail. It's just to let you know that there are some published guidelines. I think you're probably mostly aware of the NCCN guidelines that now have introduced limited resource guidelines for countries without all of the diagnostic and therapeutic interventions that we have. But again, by having a patient staged appropriately, you can look at what the actual workup should entail, and also it allows us to guide you in terms of what are the appropriate therapies based on the stage. This example right here is looking at locally advanced cases, women with stage 3 tumors, A or B, and then by following along the algorithm, you can determine what the actual treatment should be.
Donc, très rapidement, ça sont les NCNN qui c'est national aux États-Unis qui souhaitent des recommandations pour toute étape. Il y a pour early, il y a pour cancer qui a avancé, il y a qui est inopérable. Donc, là, il y a une série d'algorithmes qui dit différents examens, qui différents à vous faire. Il dit que dans l'algorithme, ça c'est les États-Unis qui ont fait. Vous commencez à mettre des recommandations particulières pour pays qui sont vieux, pour appliquer.
So I mentioned that one of the other important considerations is that by appropriately staging a woman with breast cancer, we can get a pretty good sense of what her prognosis might be and communicate that with the patient and her family. And stage is really the most important factor in terms of determining prognosis and certainly curability. This graph here was used in the determination that we should go to another staging edition, the 8th edition, which I'm going to be talking about shortly. But this looks at information for patients with stage 0 or non-invasive cancer right through stage 4 or metastatic cancer. And looking at the disease-specific survival over time, you can clearly see that as the stage increases from stage 1 to stage 4, disease-specific survival decreases. So this is kind of the starting point in terms of why it's important to adequately stage patients, so it can give us a lot of information regarding their prognosis.
Donc, slide ça est important pour ça. Nous avons une lumière, bien important. On dit, et des lumières. Oui, slide ça est important pour ça, montrer nous suivi maladie, notamment une stade. Mais au départ, on a un stade 1, on a un stade 0 qui est en bleu. Après 8 ans d'évolution, presque 97% d'eux vivent toujours. Les gens dans le stade 4 au départ, après 8 ans, c'est à peine 60% d'eux qui vivent toujours après 8 ans. Donc, tout ça, c'est important ce stade-là. Donc, un bon stade, on est capable de parler de plus de on est capable raisonnablement dire que dans 6 ans, dans 5 ans, dans 8 ans, mais il y a plus de chance pour gagner pour la vie, plus de chance pour gagner pour nous. Ça, c'est important dès le départ.
All right. So this is where it starts to get a little bit complicated. We're talking about clinical stage, pathologic stage, and now we're also talking about anatomic staging. In terms of what the clinical stage is, this is using all of the patient's information based on the history and the physical, any imaging that's done, whether it's mammograms or ultrasound, and the biopsy information. And the clinical prognostic stage, which we're using in high-income countries now, also utilizes the TNM system as well as grade and biomarker status, the estrogen and progesterone receptors and HER2 status. Imaging for clinical stage can be used to check the lymph nodes for clinical evidence of cancer. The pathologic stage is used for patients who have surgery first And it uses all of the information you get from surgery, including the grade, the tumor size, the biomarker status, and also any laboratory results on the breast tissue and lymph nodes removed during surgery. Finally, there's the anatomic stage. The anatomic stage is purely based on the size and spread of the cancer as described by TNM and TNM alone. The anatomic stage is basically what you're using in Haiti right now. I know you have ER status, but you don't have generally PR status. You don't have HER2. So the anatomic stage is the basic TNM stage as you know it and as you're staging your patients.
Bon, j'ai l'impression que je changer ça. Je changer ça là après le gouvernement. J'ai l'impression. Donc, il dit que dans le staging, il y a des cliniques pathologiques. Et c'est ça que nous faisons à Haïti, anatomique. Donc, c'est examiner malade là, c'est-à-dire toute caractéristique tumeur là importante. Combien de cette tumeur là, combien de ganglions gagné, si il y a métastase ou pas. On est capable de faire avec clinique, on est capable de faire avec imaging. Maintenant, et la stratification avec pathologie en lui-même, il implique biopsie. Lui-même, il est supposé faire la plupart du temps, capable de faire après chirurgien. Après chirurgien, par exemple, on dit non, il y a tant ganglions positifs. Ça, c'est après chirurgien, on est après biopsie que vous êtes capable de faire. Donc, avantage, c'est stratification histopathologique avec biopsie, qui précise, ça cancer, ça pas cancer. Mais lui-même, il y a des fois qu'il y a un cas important, surtout par exemple, dans le pays sous-développé, côté les bouts de résultats pathologiques, là, il prend temps pour commencer un traitement initial. Donc, c'est ça le livre. Donc, stade là lui-même, anatomiquement, il est basé sur ça nous joint dans TNM là. T, c'est pour taille. N, c'est pour ganglion. Et puis M, c'est pour métastase. Donc, dans le pays côté, nous pas gagné tout biomarqueur, à savoir œstrogène, progestérone, c'est la stratification anatomique que nous utilisons nous-mêmes.
Okay, so let's do a little bit of basic review about the TNM staging, which you're all aware of, but I just want to make sure that we're all on the same page. T being tumor size, N being nodal status, and M whether or not there's any metastatic disease.
Donc, ça me fait dire, T c'est taille tumeur, N c'est qui côté et puis qui quantité. Et puis, M lui-même, c'est d'autres parties du corps en dehors que le sein. Alors, poumon, foie, os, le bagage.
This is kind of boiling things down to the most basics. Clearly, it's important to understand that as your T stage or your N stage increase, you're going to see a worse prognosis. So for the T staging, T1 is tumor size less than 2 centimeters, although it's broken down further into A, B, and C depending on the exact size. T2 tumors are tumors 2 to 5 centimeters. T3 tumors greater than 5 centimeters. And T4, as we were just discussing, are locally advanced tumors with extension to chest wall or also to the skin of the breast. In terms of the N status or nodal status, N0 would be no lymph nodes involved. N1 would be metastatic disease to the ipsilateral axillary lymph nodes. It can also be N1 microscopic, which would be very minimal microscopic involvement, greater than 0.2 millimeters, but less than 2 millimeters. N2 disease is when you have metastasis to ipsilateral fixed axillary or internal mammary lymph nodes. And N3 is when there's metastatic disease involving infraclavicular or supraclavicular lymph nodes. And often, in addition, there's axillary or internal mammary lymph node involvement.
Donc, très rapidement, size là, nous connaissons ce qui est important. Donc, T1, c'est en bas de 2 cm, T2, 2,5, T3, 5, T4, les latines parois thoraciques, combien et les latines pour. Maintenant, pour N, N0, c'est les paraganglions du tout, paraganglions. N1, ganglion au niveau, sur même bord, N2, mais sur le ganglion mobile, c'est N1. Depuis N2, ça veut dire fixé, il profond, pour ne pas bouger. Et puis N3, c'est le ganglion en bas là, en bas de la clavicule là, ou bien pour ganglion sous la clavicule là. Donc, il y a un ganglion intra et mammaire. Donc, sur le ganglion qui là, comme ça, c'est plus difficile pour parler, mais le ganglion, c'est N3. But I have one question for that part.
Yes.
I sometimes see some documents in N2 and N1 and N2, sometimes they are being described according to the numbers of lymph nodes.
That would be in the pathologic classification. So remember, there's the clinical evaluation, what you're feeling. Say you feel a small lymph node, a single small lymph node, that would be clinically an N1. But then that same patient, you might go ahead and operate on them, and you might find 6 or 7 lymph nodes involved. So clinically, it would be an N1, but pathologically, it would be N2 involvement.
Okay.
Okay?
Yes.
All right, so the next slide, this is just to show you that once you have determined what the T stage is, what the N stage is, and what the M stage is, you can come up with an anatomic stage group, which is what you do all the time. So as a for instance, if you look down in the first column, T2 tumor, and then the N stage is an N0 tumor, and then the M stage is M0 or no metastatic disease. In the anatomic stage grouping, that would make it a stage 2A. So this is what you need to refer to when you get all the information together and you want to assign an anatomic stage. And again, this is different than what we're doing in high-income countries currently, where we are now including receptors and all the biomarkers, including HER2 as well. So why don't we go to the next one?
Donc, c'est ça qu'on fait, c'est TNM. Et puis, total là, on a l'offert. Donc, si le T, par exemple, si le T1, N1, et puis M0, on dit devenir 2A. Donc, c'est comme ça. T on fait N1, on fait M1, et puis tableau à tout, qui peut tenir. Okay.
All right, so I thought it was good to just kind of go through the stages. I know this is not the most exciting thing, but I think it's good to walk through it. So stage 1 are early cancers. It's subdivided into categories A and B. A stage 1A tumor is small. It measures less than 2 centimeters, and it hasn't spread to lymph nodes, or it's N0. A 1B tumor would be there's no tumor identified in the breast, but there are microscopic lymph nodes identified pathologically, or N1 microscopic. There is also a situation where there can be a small tumor or a T1 tumor less than 2 centimeters in the breast, and microscopic lymph nodes are N1 microscopic. Both of those situations would be stage 1B. So again, the most favorable patients generally.
So, donc, en gros, ça pour nous juste retenir de ça, c'est que c'est identifier chaque. Nous connaissons T, nous connaissons N, nous connaissons M, c'est l'orphélie, et puis vous mettez d'abord à regarder. Parce que les gens sont compliqués. Par exemple, regarder stade 1A, il est facile. Depuis masse en bas 2 cm, ou pas de grain, ou pas de grain, il stade 1A. Mais 1B à lui-même, il y a différentes options. C'est soit pas de masse dans le TTA, ou bien il y a quelques cellules, mais fort inférieur à 2 mm, fort supérieur à 2 mm, à 0,2, mais inférieur à 2, défini pour gagner dans le ganglion quelques cellules. Ou bien pour capable de gagner masse, mais fort masse inférieure à 2 cm, il y a fort pour garantir le ganglion entre 0,2 mm et 2 mm. Donc, chaque petit compliqué, mais c'est identifier T et puis mettre dans le tableau, ça permet de nous voir finalement dans quel stade 1A, 1B, par exemple.
So the next stage is the stage 2. They're divided into 2A and 2B as well. And for the 2A tumors, there can be no tumor in the breast, but involvement of axillary lymph nodes, 1 to 3 axillary lymph nodes. The tumor can measure less than 2 centimeters, be a T1 with spread to ipsilateral axillary lymph nodes or to the internal mammary lymph nodes by sentinel lymph node biopsy. Or it can be a T2 tumor, a little bit larger, at 2 to 5 centimeters with no spread, or N0, no spread to axillary lymph nodes. The 2B tumors can be T2 tumors, 2 to 5 centimeters with microscopic involvement of the lymph nodes, or 2 to 5 centimeters and minimal spread to the lymph nodes, 1 to 3 axillary lymph nodes. Or there can be involvement of internal mammary lymph nodes identified on lymph node biopsy. The last situation is the tumor is larger than 5 centimeters. That would be a T3 tumor, but it has not spread to any axillary lymph nodes.
Donc, encore une fois, c'est le même bagage là. Stade 2A divisé en 2A et 2B. Donc, ça l'important, c'est que il est capable de T0, il est capable de T1, il est capable de T2. Donc, ça va faire 2A, par exemple, c'est lymph node. Donc, il y a T0, capable de masse, il y a T1, capable de masse qui est en bas de 2 cm, il y a T2, une masse qui est en 2 et 5 cm. Donc, il y a tout T1, il y a ces N par différents. Sous des ganglions, homo et latéral de même bras, mais sous des mammaires internes pour jouer dans dissection, si vous êtes de lui-même, il faut pas de ganglion. Donc, c'est association. De même que dans 2BA, c'est le même genre. Massa capable en T2, massa est capable T2, il est capable T3. Mais si il est T3, il faut pas atteindre ganglion. Si il est T2, il faut aller dans un ganglion et dans un A3 ganglion axillaire. Donc, c'est, comme je dis encore une fois, c'est faire T à pas, faire N à pas, et puis essayer de faire un bien de mettre notre endroit pour joindre, parce que c'est ça qui dépend de l'issue malade.
So now we're getting more into the kinds of breast cancers that all of you are seeing in Haiti, the more locally advanced and metastatic cases. Just to briefly walk through stage 3, there's 3A where you have a T3 tumor, a large tumor that's spread to 1 to 3 axillary lymph nodes, or alternatively, as you can see in the diagram below, there can be a tumor of any size from not identified or T0 to a T3 tumor that's found in 4 to 9 axillary lymph nodes or in internal mammary lymph nodes without axillary involvement. So that would be a stage 3A tumor.
Donc, 3A, même ça, c'est plus cancer que nous venons, comme nous connaissons la maladie avec le masse. Donc, depuis l'esprit à 5 cm et qu'il y a au moins une entre 1 à 3 ganglions qui atteignent, pour capable de déterminer 3A pour y 3A tout, il n'est pas obligé de supérieur à 5 cm. Il a n'importe quelle taille pour y depuis pour joindre 9 ganglions. Alors, quand 4 à 9 ganglions, il y a 3 ganglions, peu importe taille là, sont et ça 3. Et puis, vous êtes capable de jouer tout ganglion dans ma main interne, c'est-à-dire sur le interne, dans le TTA, sans que on va bras pas atteindre.
So stage 3B tumors, and I think the case that Bob was referring to earlier, it looks like it was a 3B. It's a T4 tumor, and T4 tumors can involve the chest wall. That would be a T4A. There could be skin involvement with edema, ulceration, and nodule. That would be T4B, or both of those things, which would be T4C. And then finally, it also includes the inflammatory breast cancers, which are T4D. It also may have spread to up to 9 axillary lymph nodes, so it's a T4, either N1 or N2, and it may have spread to internal mammary lymph nodes in the absence of axillary lymph nodes.
Donc, soit béni même, c'est peu importe taille là, depuis il atteint soit poids, soit les là. Donc, en bas, il est capable de soit œdème, TTA des massifs qui met capable en tout. Et on bien, il est capable de tourner et puis il arrive dans n'importe qui ganglion jusqu'à 9 ganglions, de 1 à 9 ganglions, et puis il est fini, il est capable tout, pas atteindre ganglion en bas bras, mais atteindre ganglion en mammaire interne. Tout ça, c'est stade 3.
So
wait, there seems to be some questions.
sure.
Non, ou bien n'a pas fait magie, ou on a fait magie. M, ok. Ou capable, on est par exemple, ou capable d'envisager une épanchement pleural, ou capable de supposer son métastase pleural, ou capable d'aller fois par fois pour les fois de métastase pleural. Fois de la guerre, et pas tout les Oui, oui, ça dit sans imaginer. C'est là. Non. Ça c'est pour applicable pour pays qui pas de ça veut dire, oui, mais ça veut dire stratification clinique, il est moins précis. C'est certain. Donc, c'est évident, c'est une grosse effusion plurale. Mais c'est des nodules, donc, c'est image bien important. Yes. So, yes, we were discussing and pointing out that without imaging, because at first you said that we could do like clinical staging with or without imaging. And we were pointing out that without imaging, frequently, it's very unprecise.
Absolutely.
Because you will miss some, like I was saying, some long nodules as compared to you wouldn't miss a large pleural effusion, but you can miss some long nodules or liver nodules that you would have seen with either a CAT scan or a abdomen sonogram. And
right.
It's less precise.
Absolutely. So, and that's why they differentiate the different types, the clinical and the pathologic staging. And even within the clinical staging, you only have what you have. I mean, if you had all of the tools that we're fortunate enough to have, you're going to get more precise information. And as I said earlier, certainly there is a risk of understaging or overstaging some patients when you rely solely on your clinical exam. But you use what you have available is the bottom line.
Donc, on va utiliser son joint. Évidemment, si vous avez bon staging, si vous avez seulement avec stéthoscope, avec un radiographie, vous avez un qui est un petit peu moins. Donc, en gros, utiliser ça ou bien, au type ou bien. Oui. Yeah. Yes. Yeah, so in brief, we are basically saying that we are done here without the tools that you are referring to.
I'm sorry, could you repeat that?
So, in summary, we are saying that we are doomed.
No, not no, but I mean, there are things that you can do and things that you can't do. You know, as getting back to Bob's example in that case today, when you're calling somebody, you know, a T1N1, and the patient has ulceration in the skin, and it's categorized as one thing, you know, that sends you down an entirely different treatment path than if it was staged a T4B and 2, and it also gives you more prognostic information. So there's a surprisingly good deal of information that you can get just by doing a very meticulous exam and review of the imaging that you do have available.
Donc, je dis que nous pas forcément chier, mais il y a plein d'informations que nous sommes capables de prendre. Dans ça, nous gagnons du corps. Et d'autre part, l'offre staging qui est précis, pour capable d'orientation, aussi très thérapeutique qui approprié. Nous pas forcément chier.
It's also important doing the staging, if we want to go back and look at how your stage 3 breast cancers are doing, it's important that we're including all of those stage 3 patients. You follow what I'm saying? So that's why it's so important to, you know, to get it in the chart first and to get it right second.
Yes.
So, I'm sorry.
One question.
Dans les condamnés qui vivent, il y a un stade de malade, pensez que nous avons envisagé pas même d'aller en traitement palliatif, mais nous plus parler de soins palliatifs pour nous. À quel stade que nous avons nous parler de soins palliatifs pour lui, que nous pas décider même d'aller chimiothérapie.
Par contre, c'est seulement ce stade-là, et ma pose une question, quand même, je pose une facteur et clinique, comme c'est état général, comment on présenter. Par exemple, on a gagné 3, mais il y a là, s'occuper, là, un hypertension, là, un sévère, pour avoir la fin, oui. Donc, manoucha, par exemple, voilà. Tandis que, voilà, il y a chez tout, il y a des malades 4 lui-même. Voilà, 4, il y a une sensation pulmonaire, oui, mais pour tout ça. Oui, bien, la majesté c'est fini, bien fort. Donc, je pense que c'est stade-là, ça l'a compté sur le facteur, mais il y a l'autre élément tout pour qui répond sous fait à traitement, tout sensible à quelle molécule, qui comporte, etc.
Ça n'a pas tellement compté, non? Moi, dépendamment de l'état général,
oui, non, qui il y a ça là, la preuve pour ça, la matière a mis contact. Vous entendez? Yes, so the question was, at which stage do we decide not to even try like palliative treatment,
okay,
and to give comfort measure? And we were discussing, and what came out was stage could be one factor, but it wouldn't be all of it. There will be other factors like being sensible to treatment, also patient desire, and also ECOG, like how physically disabled a patient might be, and for ability to receive chemo. I don't know if you.
Yeah, no, I appreciate that. Stage is just one factor that we utilize in making a treatment decision. Obviously, patient's performance status, comorbidities, intolerance to certain types of therapies, all of those things will play into the decision. But as a starting point, I think it still is important to adequately stage a patient first, and then look at the other factors second in determining a treatment plan. It's not, if you know the expression, one size fits all. Certainly there are patients who have stage 3 breast cancers that may not be a good candidate for treatment because of all their other medical issues, or they may not be a candidate for adriamycin given a cardiac comorbidity. But I think, again, I can't emphasize enough, whether it's breast cancer or cervix cancer or any other type of cancer, as a starting point, I think you need to know what you're dealing with and follow the same pathway in terms of evaluation to develop a plan.
Donc, en gros, c'est ça, c'est un facteur qui va s'aider, c'est pas un premier pour garder, pour orienter prise de décision, mais c'est un facteur pour l'empathie, pour l'obésité. Il y a un malade castatoire, il y a un problème cardiaque, il n'y a pas de recevoir à diagnostiquer. Donc, malade ça, on n'a pas essayé, par exemple. Donc, c'est un facteur de dépassement. C'est pas stade là. Avant ce stade, on doit commencer à dire.
Do you
So-
hear me?
Yes, do you hear?
Yes.
Yes.
Yeah. Earlier you were talking about prognosis. At the time of the prognosis, you can say approximately how long a patient will stay alive, right?
Well, I think by determining prognosis, you can know, you obtain a statistical probability. You can't say how long this patient is going to be alive, because for any individual patient, they may be cured of their disease or they may not. And what you can tell them is that for a patient with, a stage 1 or early breast cancer, that the majority of those patients are going to be alive and probably cured of their disease, greater than 90%, certainly. You can't say that with a stage 3, but you can't tell a patient definitively, for you, you're going to live 5 years. It just gives you a probability.
Okay, is it for only high resources countries like US or other countries? Do you think it is valid for Haiti? Because in Haiti, my sense is that you have to take into account other factors.
Absolutely. And again, I think it gives you a starting point. It doesn't answer all the questions, certainly. And you're absolutely right that you're dealing with a population, who has a high chance of having HIV or malnutrition or other types of comorbidities that may play into it. Also, it's much more difficult for many Haitians to get to the hospital and to complete their prescribed course of therapy. So you're absolutely right. But again, that's one of the reasons why we want to start collecting data for Haiti, so we can give your patients a better idea of what the likelihood, not only for a woman with a stage 3 breast cancer, but a stage 3 breast cancer in Haiti, what her prognosis is going to be.
Okay.
Okay, so
Yeah.
I think we have 2 more, and then I think I had a couple more, but I'll stop after that. So why don't I just finish up here for the stage 3C tumors. This is a fairly easy one. The tumor can be any size, but it has to have either spread to 10 or more axillary lymph nodes or to the infraclavicular or supraclavicular lymph nodes. So we're talking about the lymph nodes are quite advanced in this situation. And again, as you would expect, these patients have a slightly worse prognosis than the 3As and 3Bs.
Donc, ça 3CA, c'est pas important. Là, ça qui est important là, c'est qu'on dit, donc, on peut aller jusqu'à 10 ganglions axillaires, ou bien, comme est-ce qu'il y a de l'autre côté, infraclaviculaire, ou bien supraclaviculaire, ou bien mammaire. Donc, nous commençons à dire ça, c'est stade 3C. Donc, évidemment, nous avons commencé le très bon stade là. Très important là, il y a très comme c'est pronostic très sombre.
So I think I'm going to stop after this slide. There are a couple more that you can see, but basically for the stage 4 tumors, this is the metastatic cases, and this is a lot of what you see. Patients who have hematogenous spread or spread by blood to different organs in the body. There can be lymph nodes involved or not. The sites that we see, and I just picked out a few X-ray examples to show you. Number 1 on the left, that's a right humerus with a totally destroyed proximal humerus by lytic breast cancer. The second one is a axial CT slice of somebody with innumerable liver or hepatic metastases. The third one, you can see the chest X-ray with nodules scattered throughout her breast from her breast cancer. And then the last is an axial CT image of multiple brain metastasis, all of those from breast cancer. And those, the breast cancer can spread to other sites, certainly, but those are the most common ones that we're seeing. And with any metastatic disease beyond the lymph nodes, that would automatically put them in a stage 4 category.
Donc, stade 4, c'est peu importe TTDI, peu importe le lion, c'est depuis gagner atteindre l'autre partie autre que c'est. Il est capable de zone, capable de foie, capable de poumon, capable de cerveau, capable de partie de quoi encore, principalement.
Yeah, bigger ones. Yeah.
Yes.
All right. Any was that helpful? Any questions?
Yes, I have one question regarding that slide and about survival. I know that stage 4 has the worst survival, but are there like any subcategories in the stage 4s? Like, do you have less average time left if you have like brain metastasis as compared to lungs or liver?
Yeah, good question. Generally, the patients with bone-only disease and low-volume disease, generally speaking, they're going to live longer. Certainly, when there's visceral involvement involving things like liver or brain, they tend to have a worse prognosis. Again, remember that this is only part of the picture. We're not even talking here about what their receptor status is, whether they've already received any prior therapy, what their comorbidities are. So there are a lot of other factors, as we're talking about, that play into prognosis. But certainly, even within the stage 4 group, there are women who actually have an exceptionally favorable prognosis. So a woman with very low volume disease, some bone metastases, low volume, that's estrogen and progesterone receptor positive, she may have a much better prognosis than somebody with high volume liver disease, triple negative breast cancer. So there are a lot of subgroups within the stage 4, certainly in terms of prognostically, and also you need to factor in what their local disease looks like as well, because there can be a lot of issues in terms of the actual local disease on the breast and lymph node areas that we're not talking about here.
Même si, comme si il va y avoir seulement H2 et un paquet d'autres éléments, dans cette statut, il y a d'autres récepteurs qui sont capables de conditionner. Et puis tout établi, c'est une étape masse, si nous avons une grosse masse qui ferme, on qui est dans une masse, qui marche pour les péter, c'est deux barres différentes.
Est-ce que ça veut dire c'est pour Haïti? Parce que si on est négatif et HER2 positif, est-ce que la capable de
Non, moi je dis, parce que je ne peux pas dire l'autre, je dis comme ça, par exemple, c'est état récepteur en général, c'est seul. Mais il dit tout là-bas, sous triple négatif,
non, triple négatif, pas HER2 positif à PIA, mais HER2 positif là-bas avec IE négatif.
Oui. Donc,
il pas servi à rien.
C'est comme si on est négatif, parce que nous regarde, avant de regarder dans ce parti là-bas.
Great. Well, thank you very much. Sorry we went so long, and reach out to me directly if you have other questions.
Non, bon, pour question, pour plus dérangement, puis moi-même, dans le traitement panneau, pour le côté advanced cancer que nous avons néoadjuvant, est-ce que nous ne pouvons pas tout dans le traitement palliatif? Okay. Ça vraiment dérangé.
Oui. Okay. So, Dr. Satin is saying that she has like a thought that is bothering her is for all the locally advanced breast cancer patients, and a lot of them that we have in Haiti, we sometimes give them neoadjuvant treatment. and she's saying, wouldn't it be like an option to give them directly palliative treatment because they may not be curable?
I say that because I saw when we give neoadjuvant treatment and send the patient to the mastectomy, and they become quickly metastatic, early recurrence and metastatic, and became also metastatic quickly. Sometimes 3 months after the surgery, sometimes when the patient taking the adjuvant treatment, they present a recurrence.
I would, maybe if there are any of the medical oncologists on, we could have them chime in, but I would suggest that in terms of when you're giving neoadjuvant therapy, it's even more important before considering neoadjuvant therapy to make sure that the patient is adequately staged and does not have metastatic involvement of, you know, the lungs or the liver, because most of those patients who go on with neoadjuvant chemotherapy and then have surgery and then 2 months later are found to have metastatic disease everywhere, they probably had that metastatic disease before you even started your chemotherapy. So that's why, you know, when you can, getting a liver ultrasound, even doing a chest CT. Oops. Okay.
Call it a wrap.
Okay, we'll call it a wrap.
Great job.
I think they got it.